Good afternoon. My name is Dr. David Sandberg. I am a pediatric neurosurgeon. I'm the director of pediatric neurosurgery at Children's Memorial Hermann Hospital, as well as the University of Texas Health Science Center at Houston and Misher Neuroscience Institute. Our topic for today's webinar is intracranial arachnoid cysts, the latest treatments. So first, what are arachnoid cysts? You can see on the right a CT scan. The two sides of the brain are supposed to look the same. And you see on this CT scan this very large dark space which shouldn't be there. You can see there's normal brain on the other side. And on this side, which is the right side of the brain, right and left are backwards on CTs, there's a very large lesion which has fluid which is the same density as the fluid which circulates around the brain. And this is the typical appearance of an arachnoid cyst on a CT scan. And I'll show you some MRI scans as well. But basically, arachnoid cysts are benign lesions. They're not cancers, so we say they're non-neoplastic. They constitute about 1% of mass lesions which are found in the brain when imaging studies are performed. The overwhelming majority of them are diagnosed in childhood, but sometimes patients can be asymptomatic from arachnoid cysts and they're never diagnosed, or they're diagnosed in adulthood when a patient becomes symptomatic or it's discovered incidentally. There's a male predominance, 3-to-1 males to females, for uncertain reasons. And the most common location, about half of these, are where this arachnoid cyst is that you see on the screen, which is in the middle cranial fossa of the brain. So many parents ask, why did this cyst come about? What is the cause of arachnoid cysts? And in the overwhelming majority of patients, we don't know the answer. The cause is unknown. Most are considered congenital because they're often found soon after birth in patients who are imaged for various reasons. Histopathology, in other words, if you look at these under a microscope, if you take out the membrane and show it to a pathologist, what they'll see is a single layer of cells which are comprised of arachnoid cells. Arachnoid is a thin, wispy layer of tissue which sits right on top of the surface of the brain, and it's in a vascular membrane. Vascular meaning there are blood vessels within it. And that's important because, as we'll talk about later, these arachnoid cysts can bleed after relatively minor traumas. The cysts are filled with clear fluid, which most assume is chemically indistinguishable from cerebrospinal fluid. Years ago, I and some other colleagues did a study where we found that actually, in some cases, the cysts have higher protein content than the typical fluids, the cerebrospinal fluid, or CSF, which circulates around the brain. The importance of this is unknown. So, many arachnoid cysts, such as the two that you see in these MRI pictures below, are very small. Here's a very small middle cranial fossa arachnoid cyst, and here is a very small cyst in the back of the brain at the cerebellopontine angle. Many cysts like this are incidentally discovered. Children and adults get MRI scans and CT scans for a variety of reasons, after trauma, or they're having headaches, or a whole host of other reasons that patients get imaging studies these days, and we discover these cysts, and many times these cysts have absolutely no relationship with the reason that the study was obtained. So some cysts can be small, they can be asymptomatic, and don't expand over time. Others can start out small and expand, and I'll show you a picture, at least of one of those. So the question that arises, which many parents ask, is how often should we obtain imaging studies in a patient like this who's asymptomatic? And the answer is we don't know. But the overwhelming majority, if you obtain imaging studies over time, year after year after year, the cysts remain the same or have minimal change. So very important, there's no accurate way of predicting which intracranial arachnoid cysts will remain stable over time and which will expand. And we don't know why the cysts grow. We have 3 different hypotheses that are here. For those of you who are more interested in pathophysiology, there are some scientists who would suggest a one-way valve mechanism in which fluid can enter the cyst but can't come out. Some scientists talk about the secretion of fluid by the cells within the lining of the cysts, and others talk about an osmotic pressure gradient between the cyst and the adjacent fluid spaces. And when I talked about the protein content, that may play a role. If there's higher protein content within, that could potentially force fluid within the cysts so that the protein content equilibrates between inside and outside of the cysts. This talk is not about pineal region cysts, but I do want to mention them because they're very common. And you can see the MRI scan on the right shows this perfectly round circular lesion within the center of the brain sitting in the pineal region. These are found in almost 2% of children who have an MRI scan for any reason whatsoever. If they are under 1 centimeter, they're considered a normal variant and they're unlikely to grow or cause symptoms. So the overwhelming majority of pineal region cysts do not need neurosurgical intervention. On this slide, you can see a picture of a very large middle cranial fossa cyst. So here's the cyst on the left side of the brain, and you can see that it occupies much of the left hemisphere, and there's much less brain on this side than there is on the right. I think you can also appreciate that the midline, which should be sitting here, is shifted over, and the ventricle, this is the ventricle on the right side, and this is the left, the ventricle is a little bit compressed. So this large cyst is causing what we call mass effect on the brain. It's causing pressure on the brain, which is pushing the brain over. It's also causing pressure on the bone. You can't see the bone as well on an MRI scan. CT better depicts bone. But very often we see that the bone of these children, when you have a large arachnoid cyst, is much thinner on the side of the cyst compared to the other side. And this is important for trauma, and we'll talk a little bit about trauma in a little bit. So in very young children, we sometimes see a presentation with increasing head circumference. All of you, when you take your baby to the pediatrician, they measure the head circumference on a routine basis, and the head circumference should follow a steady curve. If the head circumference starts to cross percentile lines, meaning, for example, it used to be in the 25th percentile, and then it's the 50th percentile, and then it's the 90th percentile, one of the causes could be a large cyst in the brain, which is causing the head to grow at a rate that is more rapid than normal. In most patients who are older, they'll present with headaches. That's the most common presentation. Other symptoms of elevated intracranial pressure or seizures. And there's some controversy over whether seizures related to these cysts can be treated by treating the cyst, or whether they're an unrelated finding and that the brain below is not normal, etc. There's certainly plenty of controversy about arachnoid cysts and their presentation and management. So I mentioned hemorrhage within arachnoid cysts. This is a picture of a blood clot, as you can see on the right, within a middle cranial fossa cyst after relatively minor trauma. And one of the things that we know that can happen is that you can have bleeding into cysts with relatively minor trauma, a fall from a low height, a minor sports injury. Sometimes that bleeding just causes headaches, and other times, rarely, it can be life-threatening. But the entire fluid space that usually contains just spinal fluid can be filled by blood, and that blood can continue expanding and push on the brain and cause significant problems. So at the very least, parents whose child has an arachnoid cyst should be cautious about head trauma. And we have long discussions in my office about participation in athletics, etc. Certainly every child, and especially children with an arachnoid cyst, should be wearing a bicycle helmet every time they get on a bicycle. Every single child should be doing that, as should every single adult. I personally limit contact sports in patients with arachnoid cysts because I'm worried about bleeding into the brain with relatively minor trauma. So as I mentioned, many arachnoid cysts are very small and don't require surgical treatment at all. Others, because they are large and or symptomatic, require treatment. And this is not a medical problem. There is no medicine that is going to make these cysts go away. So once the decision is made that a child is symptomatic and requires treatment for a large arachnoid cyst, there are 3 options, and we'll talk about the advantages and disadvantages of each. So the first option is shunting, which I try to avoid for many reasons in the majority of patients, but occasionally do. There's open fenestration via craniotomy, which is a very common accepted approach for these cysts. And there's endoscopic fenestration, which accomplishes the same thing as the open craniotomy in general with a more minimally invasive approach. And there's great controversy among pediatric neurosurgeons regarding which is the best approach in any given patient. It's not uncommon for patients whose parents go to have more than one opinion to hear very different things from different doctors because there's a lot of controversy about what is the best approach for these lesions. So here's an example of shunting, and shunting can be very, very effective for both hydrocephalus, which is when the fluid doesn't circulate properly in the brain, but also for arachnoid cysts. So this was an infant who presented with macrocephaly, meaning the head was growing at an abnormal rate. And you can see this absolutely massive cyst, which is literally filling most of the brain. And it's pushing the remaining brain that is present very far forward. And so in terms of options, I decided to put a shunt in this cyst because while my favorite approach in general is endoscopic fenestration, I did not see a good place to endoscopically fenestrate, or fenestrate means to make communication between the cyst and other fluid spaces of the brain. So I placed a shunt in this cyst, and you can see a number of months later, a dramatic change in the brain. That space that used to be filled with fluid is actually now filled with brain, which has expanded, and the child has done beautifully. So that's a wonderful, wonderful outcome. And so with outcomes like this, why not just put a shunt in every patient? Well, the reason has to do with shunts themselves. So why not shunt all arachnoid cysts? Because shunts have a very high complication rate. Now, for all comers, there's a 30 to 45% failure rate within the first year of shunts. On the right, you can see a few images of failures of shunts. Here's a shunt that's eroded through the skin in an infant who's not well nourished. Here's a shunt, an x-ray of a shunt which is broken in the clavicle. And what I tell parents is that shunts are like your car or your air conditioner. They can work perfectly, and then unexpectedly they fail. So there are some kids who are lucky enough to have one shunt placed and never have any revisions, but they're the exception because there's a 30 to 45% failure rate in the first year and a 4 to 5% failure rate every year after the first year. So many children who have shunts placed have surgeries throughout their childhood when a shunt that they become dependent upon fails. There's also nationally a 5 to 10% infection rate for shunts. Now, we have a protocol to minimize shunt infection, and our rate is now around 1%, which is dramatically lower than the national average because we're so careful to avoid shunt infection. But even 1% is too much, and you're implanting hardware into a body where it's not supposed to be, and that hardware can become colonized by bacteria and can cause a serious infection. So for that reason, I try to avoid shunts, but as I showed you in that one example, there are selected patients who receive them. The next option, which is a very reasonable option, is open fenestration via craniotomy. And it's not just middle cranial fossa cysts, there are cysts everywhere that can be treated in this manner. So as you can see in the images, this is a large middle cranial fossa arachnoid cyst which is pushing on the brain in a young child. And so an incision is made, which is a little sort of reverse question mark incision. Underneath that scalp flap, we remove a piece of bone, and then you're looking at the dura. This is the dura of the brain, which has been flat back, and what you can see is the outer membrane of the arachnoid cyst. And if you look closely, you can see all these little blood vessels in it. And so it's no surprise that with bone that's thinned out and a relatively minor trauma, some of these little blood vessels can bleed. So we excise that outer membrane of the arachnoid cyst, but that's not the important part of the operation. The important part is not to excise this membrane on the outside, but to create a communication on the inside. So we open the inner membrane under the microscope, and we enter this space. These are called the basilar cisterns, so that fluid can communicate freely between the basilar cisterns and the arachnoid cyst. And our hope is that the cyst then decreases in size and doesn't cause complications, and that the symptoms that the patient presented with will resolve. Here's another example of a patient who had a craniotomy for an open fenestration of an arachnoid cyst. This is a 10-year-old girl who presented with headaches. And you can see that she has a large cyst in the back of the brain, which is sort of pushing the midline of the brain over. And there was not a good way to endoscopically fenestrate this, so we made an incision in the back of the head, entered with a craniotomy, which means removing the bone, which we put back at the end of the operation, opened the cyst, made multiple holes in it, and the patient did very well, and her headaches improved postoperatively. So the next way, and the final way of treating these arachnoid cysts is with what we call neuroendoscopy. An endoscope is basically an instrument that has a small camera. There are different types of endoscopes. There are 3 endoscopes pictured here in this slide. There are just small non-channel diagnostic endoscopes, which would not be used for a case like this. There are rigid endoscopes, which would be the most common endoscope used, where there's a camera that is attached to the endoscope, and you get good visualization on a television monitor, and through ports you can introduce instruments and perform the work of the operation. There are also flexible channeled endoscopes, which you can also introduce instruments, but the optics are not as good as the rigid endoscope. So these are the most common endoscopes that we use for this particular procedure. And here we are working with our endoscope, and we have our camera in the brain, and we can see what's going on the television monitor. And the nice thing about neuroendoscopy is that rather than doing a big incision, which can often require a longer hospitalization, is more painful, we make a very small incision, just a few centimeters on the top of the head or at the appropriate place, and we can enter and really often perform the same thing that we can accomplish with an open craniotomy in a much less invasive way. So sometimes we treat cysts that are within the ventricles, which are the fluid spaces of the brain. So here's an example of a 7-month-old girl whose head kept growing and growing. She was over the 98th percentile with a very full fontanelle. That's the soft spot of the head. So clearly she had increased pressure in the brain. These spaces are the ventricles, which are absolutely massive. And the reason they're massive is that there is a large cyst filling what we call the suprasellar region, which is right above the pituitary gland, and filling the 3rd ventricle of the brain, which is preventing fluid from flowing normally. So we go in with our endoscope by making an incision on the top of the head, a small incision. We enter the ventricle. We make holes in this outer membrane and the inner membrane so that the fluid space of the arachnoid cyst communicates with the ventricles. And I'll show you now some intraoperative images. When we enter into the lateral ventricle, that first big fluid space you saw, this is called the foramen Monro, where fluid likes to pass, and it's much larger than it should be. And we see that cyst membrane, which has little fine blood vessels in it. We coagulate it so that it doesn't bleed when we enter it, and then we cut it, and then we enter and we see a bottom cyst that we can excise, and this is the basilar artery that we're looking at, and this is the posterior cerebral arteries on each side, indicating that we've entered a space called the prepontine cistern, which is the space in front of the brainstem, showing that we have communicated both the outer membrane and the inner membrane of the arachnoid cyst with the ventricles. So here's before surgery on the left side, and you can see that 1 year after surgery, the brain looks more relaxed, the spaces are more normal, the ventricles, while still large, are smaller than they were, and you see this black turbulent flow, which indicates that with every heartbeat, fluid is being forced through the holes that we made. And here's 2 years after surgery, and the ventricles are much normal. And this child is more than 5 years out of surgery, has never needed another operation, is normal neurologically, in normal classes at school, and completely thriving. Here's another example, and we're going to show a video so you can see what we do in surgery. So any of you who are squeamish, you can turn your head for the video, but it's not bloody or particularly scary to see. But this is a 4-year-old girl who presented with language delay. Now, language in most of us is on the left side of the brain. She was right-handed, and you can see on this MRI scan that she has a massive middle cranial fossa arachnoid cyst, which is compressing the left side of the brain. You can see that the ventricle is obliterated where it's normal on the right side. On the left, it's totally squashed. And so we're going to show a video now in which we show exactly what we did with our endoscope. Here we are beginning. And so we've already entered the outer membrane of the cyst, and we can use our working instruments to pop holes in the inner membrane of the cyst. So you can see we've made a hole, And now we can use a variety of instruments to widen the hole. This is an embolectomy balloon. So we stretch that hole out that we made so that that hole doesn't seal over. And we love to see a big hole. You can see with every heartbeat, it's bounding. There's fluid being forced in and out of that hole. We have a wonderful endoscope, which just came out. We were the second center in the country to obtain this endoscope, which has 2 excellent working channels. So you can see here we're lifting up the arachnoid membrane and then cutting it. We have to be very careful because right behind us is a very important blood vessel, the middle cerebral artery branch. And if we hurt this, the patient could have a stroke. So these operations are not without risks, but at centers where these are done frequently, these operations are very safe. And so here we are cutting a membrane. We're right near the optic nerve. And we want to create a huge opening in several places in the inner membrane of the arachnoid cyst. So we can use micro scissors, little microscopic scissors. Here's another hole we've created that's bounding. And that's the end of the operation. We take our endoscope out and we close the skin. And that patient will typically stay in the hospital for 1 to 2 days. And here's the outcome in that patient. This is before surgery on the left, and on the right, you can see that the cyst is dramatically decreased in size. You can see more brain on this side compared to what you saw before surgery. And now the 2 ventricles are equal. And we'll have to follow her over time and see if her language development improves. This is a very interesting case, and I want to show it just to show the importance of follow-up for these patients. Now, what you can see here is in a 3-month-old who got an MRI scan for unclear reasons. There's a very tiny arachnoid cyst right at the middle cranial fossa, but a fraction of the size of some of the cysts we've shown. And you can see it here in the coronal image as well, a very tiny arachnoid cyst. What I would do if this patient showed up in my practice is repeat an imaging study about 6 months down the road, just to make sure, especially in a young child, that it wasn't growing or changing. If I found this in an adult, perhaps I would get 1 additional imaging study 1 year later to make sure it wasn't growing or changing, but I would be much less concerned in an adult. But in an infant, you have to keep an eye on these things. And here's what happened. So the patient got an MRI for unclear reasons, and 1 year later, the plan was not to get any additional imaging studies. This same patient had an enormous head, had been reassured multiple times by the pediatrician because they had gotten an MRI scan, which was read as just having a tiny arachnoid cyst. And that little tiny thing grew into this massive, massive cyst, which was pushing over the brain, which was somewhat astonishing. Now, this is a little bit unusual, but it does happen. And that's why I wanted to alert our audience to cases like this. And so we did an endoscopic fenestration, just as we did in the last case. This is 6 weeks after surgery. Already you can see that the massive cyst is smaller. There's fluid circulating around the surface of the brain, and the lateral ventricle, which was very compressed, is much more normal. Here's 1 year later, and the cyst is almost gone, and it looks much closer to what it was before the surgery. So we can have wonderful outcomes with a very little incision overlying the cyst and a 1 or 2 day hospitalization. So bringing this talk to a close, this is a relatively brief talk because it's a relatively straightforward topic. Most arachnoid cysts that we see do not need surgery or any other treatment. So the overwhelming majority of parents who bring their child to our office who have an arachnoid cyst are told that this is something that we need to follow, but we don't need to do anything about it. But we do need to obtain repeat imaging studies to make sure the cysts are not growing or changing. There are some patients, however, because the cysts are massive or because they are symptomatic, who will require surgery. And options include shunting, open fenestration, and minimally invasive endoscopic treatment. And personally, I think that it's important to have all of these options within your armamentarium to be able to offer the right operation to the right patient. My preference is always with the endoscopic approach because I like doing things in a minimally invasive way. It's less painful for the patients. I like avoiding a craniotomy, and I also want to avoid a shunt because shunts have a lot of complications. But many children who have shunts can lead normal lives. All of these operations can be effective, and we choose the right operation depending upon the clinical presentation of the child, the age of the child, and the imaging features of the arachnoid cyst. And so the majority of patients, no matter what we do with these arachnoid cysts, have fantastic outcomes. So I want to thank you for your attention. This is a picture of our center, which is Children's Memorial Hermann Hospital, and I'd be happy to answer any questions that anyone might have. So just give me a minute as I read through some of the questions which are coming in. So the first question which was asked is, earlier you mentioned that you were concerned about sports in the future. Does that depend on where the cyst was located, or is that for all cysts? So great question, and it depends upon a lot of factors. It depends upon the age of the patient, whether the bone is thinned out and how thinned out it is, and the size of the cyst. If somebody has a very large cyst and they have very thinned out bone, in my opinion, not based upon any published literature or science, but just based upon common sense, that patient is more likely to bleed into that cyst, and more caution is urged. Patients who have a very tiny arachnoid cyst where the bone is normal probably have similar risks to the general population. But we have a very nuanced discussion with the families. The next question is, how long do you follow a patient after surgery? And the answer to that question is, as a pediatric neurosurgeon, I follow patients for a long time because children can do unpredictable things. But I would say a typical course, for example, let's say you have a patient who has a large middle cranial fossa arachnoid cyst who has an endoscopic procedure. Typically, they'll have a 1 to 2 day hospitalization. After the surgery, when they're discharged, I will see them in the office about 1 week later just to check on the incision. And then about 6 weeks later to about 3 months later, we'll obtain a new MRI scan, which will be a new baseline. And then depending upon what we find, we will certainly obtain subsequent imaging studies. If the cyst looks fantastic, decompressed, the patient's doing great, symptoms are gone, we might see the patient in 6 months to a year with a new MRI scan. And then eventually we'll see the patients annually. Now, if a number of years go by, 5, 10 years, and the patient is absolutely perfect and every MRI looks the same, eventually we may tell the families to come back only as needed. But we are very slow to do that. In general, we want to see these patients and make sure they're doing well in the long run. The next question is, my son had an endoscopic fenestration at 1 week old that dehisced. He had to have an open surgery at 3 weeks old, and now he has a huge scar on his hairline. What do you recommend that can be done to cover up this scar? Well, first of all, I'm sorry that happened. That is very unusual. That's not a problem that I've ever seen after one of these endoscopic fenestrations. But of course, any wound can have complications. That would really be a better question for a plastic surgeon. So if you go to a plastic surgeon, sometimes they can excise that big scar and bring the skin nicely together and have a thinner scar than the scar that your son currently has. So the next question is, how often should the very small arachnoid cysts be imaged? And the answer is nobody knows the answer to that question. But because of cases like the one that I showed at the end, where a small arachnoid cyst expanded dramatically, I will always obtain at least one follow-up imaging study. And the interval of time in terms of obtaining that study will depend on the age of the patient. So if I have a patient like that patient who presents at 3 months of age, I will be more inclined to get an earlier follow-up scan, let's say at 6 months, and not wait a year or longer before a follow-up study. But it's patient to patient dependent, and this is more the art of medicine, not the science, because this is not something that has been well studied. So the next question is, my daughter has a large arachnoid cyst in the middle cranial fossa, and observation rather than surgery was recommended. What are your thoughts on this? So the answer to that is, it's impossible to comment on any individual case without actually seeing the patient, seeing the imaging studies, hearing about the presentation, examining your child, etc. In general, I worry about very large arachnoid cysts that push the brain over. We worry about the function of that brain that is being pressed over, and in younger children, we worry that they can cause so much compression of the ventricle that that ventricle can obstruct, and you can take a situation which is not emergency and have an emergency situation in which the ventricles don't communicate. That's called hydrocephalus, and patients can become very sick. And I have seen patients present very, very sick from these arachnoid cysts, which have not been previously diagnosed or not previously treated. So I worry about very large cysts, but there are some large cysts that we do follow, depending upon the age of the patient, the compression of the lateral ventricle, whether the bone is being thinned out, etc. And the next question, which I think is the final question that I see, is how do we find you if we want to make an appointment? And the answer is you can call our clinic anytime at 832-325-7234. And it looks like another question just came up, which says, after surgery, do you recommend seeing the same doctor over the lifetime that did the surgery? And the answer is, in general, yes. I mean, if you have a relationship with that doctor and the doctor and your child has had a good outcome and there's nothing that you're concerned about, certainly it's better, for everybody for you to follow up with that doctor. Of course, if you have a concern that the right thing is not being done, then you should, of course, obtain a second opinion from another pediatric neurosurgeon. The next question just came up is, are there any language or developmental delays in children that have had arachnoid surgeries? So with these arachnoid cysts, I have personally, in my own experience, never seen a new neurological deficit, meaning a new neurological problem, whether it be language delays or developmental delays or motor problem or anything else in these surgeries. And I think such complications should be rare in experienced hands. Of course, any surgery can have complications, and there's a risk of stroke and many other complications that can cause long-term problems. The only developmental delays or language delays that I have seen personally are those that existed before the surgery, which were the reason for the presentation. Sometimes those persist after the surgery, and sometimes they improve. And I think there seem to be no more questions. So I want to thank you all very much for your participation in this webinar, and have a great day.